Hi. Nice to meet you.
So I'll start with introducing Dr. Hugo Decker. Dr. Decker is a board-certified fellowship-trained neuroradiologist and clinical assistant professor in the Department of Radiology at Stanford University. He has over 6 years of experience in radiology and specialized training in diagnosing injuries of the brain, head, neck, spine, and associated vascular structures with CT and MRI. Dr. Decker's primary research interest is improving the acquisition of clinical MRI protocols with an emphasis on improving speed and image quality for clinical applications. And then we have Dr. Suzanne Theron. Dr. Theron is an associate professor of neurosurgery in Stanford School of Medicine. Dr. Theron is trained as a genetic scientist and neurosurgeon with a specialization in complex spine surgery, especially a clinical focus on myelopathy. Her research program encompasses the molecular controls over cortical neuronal development, spinal cord injury, and regenerative strategies for spinal cord repair, including stem cell-based strategies. As a practicing neurosurgeon at the Palo Alto VA and Stanford Healthcare, Dr. Theron is dedicated to translating an understanding of neural development into regenerative strategies for the treatment of spinal cord injury. And then we have Sandrine and Julian joining us as well. I'm just going to pass the mic. Maybe there's something else you'd like to include about yourself. You go.
Not much. I have a prior life doing brain bold fMRI, but no longer in my research. But it's fun seeing fMRI being applied to the spine.
Well, what Ken left out is that I started collaborating with him about a year ago, and it's incredibly exciting. We're looking at patients with degenerative cervical myelopathy, and I just thought it was so exciting the way you're looking at the entire corticospinal system, which I treat clinically. And then very separately in mice, I study its development. And so like that you would just be thinking about the whole circuit and taking these beautiful pictures is like very exciting. So I'm new to what you guys do, but like very excited by it. And then Ken and I recently starting to do this in mice as well. So yeah, that's
awesome. So super excited to have you here. I think what I'm excited about is to have Hugo, you here from neuroradiology standpoint. A lot of us are more on the MRI acquisition side, the analysis side. You know, we want to make everything more quantitative. We're more quantitative. We don't necessarily care how long the imaging takes, as long as it's better and higher resolution. But there's also that sort of you have to be practical about it. And what can you fit into the standard spine protocol? What can you do clinically? We'll scan somebody for an hour or more. That's not feasible clinically, right? And also to try to get, what you would like to see better for neuroradiology. What could improve your practice, maybe from the image acquisition side, analysis side. And then Suzanne, you're the one going in and cutting into these patients who need these things removed. You're seeing the pathology right there in front of you, and yeah, how could imaging help improve what you're doing? What are you not confident about? What are you really confident about? Kind of these things, just to have a discussion about what we can improve. So I guess to get started is I'll start with you, Hugo. What can we done to make your life better and help the patients the best?
Yeah. So I think some of it will definitely be imaging, and we'll touch on that. I think another part is, and I'm sure you've seen this, is there's just inconsistency in radiology reporting of degree of severity of disease. And I think a big part of that is there isn't a feedback loop. So we grade something, and whether it gets intervened on or not, we don't see the outcome of that. And so I think it's quite difficult to know whether degree of canal stenosis, degree of foraminal stenosis correlates with patient symptoms, and whether resolving this compression, how much of that leads to patient improvement. So I think that's sort of like a larger systems question, and something that requires a department of radiology, neuroradiology, and musculoskeletal radiology, working with the musculoskeletal surgeons and the neurosurgeons to sort of come up with an agreement. And it's just not there. So that's sort of a larger question. Then in terms of imaging, so I'd say there's spinal imaging and spinal cord imaging. And I think the spinal cord imaging is not great for cord lesions or cord signal abnormality. Granted, if you have very severe compression, you'll mostly see that cord signal quite easily. But with multiple sclerosis, any bit of noise, and you start wondering, is this a real lesion or is this noise? And you try to confirm it on the sagittal and the axial, but it gets difficult. So we've played a little bit with 3D imaging, just so that anatomically it's a little easier to look at than these thick slices, but we sort of lose the contrast, and we lose some of the in-plane resolution. And so this is particularly of concern sort of in the thoracic spine, where we do even thicker slices and thicker skips just to fit the entire thoracic spine in a reasonable amount of time. So those are some of the bigger issues that I'm seeing now.
Thank you. I'd like to jump on the two sections. The first one about you being frustrated, not having some feedback and so on. I was actually curious. You don't have access to the information about patient symptoms, clinical symptoms, and so on when you do those reviews.
Sorry, we do have definitely symptoms before when we're viewing the images, but we often don't get any follow-up on that.
Exactly. Yeah.
You know, with patients, so I'll step back. Back pain is very ubiquitous, and many patients get a lot of imaging. Mm-hmm. And it's sort of hard to follow up all of those patients. With multiple sclerosis, for example, less so in the spine, but brain imaging, we now are using software that helps track lesions across time, and we will do a comparison to the prior, but it's nice being able to see that quantitative change over time.
Yeah.
For the spinal cord, we will look at the past imaging and make our subjective assessment, mm-hmm. but there isn't really there is no quantitative change in time to look at.
What software is that?
We've used a few in the past, but we're currently using for multiple sclerosis, icometrics, or we've used NeuroQuant for other things.
Okay. Okay. And on the second...
I also wanted to say, after we make a determination, say okay, we've called this severe spinal canal stenosis. We do that frequently enough. We're not going to follow up every patient to see, did they do surgery on it? How did that improve? Yeah. Whereas for a tumor or something like that, where it's less frequent, we'll do that.
Mm-hmm, mm-hmm.
Yeah.
And about the second category, about the imaging, you said you tried 3D imaging, and I was curious if you've also tried 3D MP2 RAGE, which some sites increasingly use for MS, because the hypointense lesion is very well contrasted, and it provides also isotropic resolution. I know that NIH has implemented that now in their clinical routine and other centers. So I was just wondering if this is something you try. It's a bit long, though.
We have not. Yeah, we haven't.
Yeah.
Yeah.
Thank you.
I guess I just have a question too, because we also talked about the spinal cord signal homogeneity, and you mentioned this already a little bit with the 3D imaging, kind of it not being too much inhomogeneity that it's questionable, right? Whether that's a multiple sclerosis lesion or not, and kind of keeping away from doing the 3D imaging as well, right?
Yeah. Yeah. So, not having tried that, we've the times that we what we have tried is just 3D T1 spin echo and 3D T1 GRE post-contrast imaging. And we sort of started using that for stereo acquisitions, for cyberknife planning, and at least typically those images, those 3D images, look better than the axial 2D acquisitions that we get, but we still enjoy having the sagittal 2D images, particularly for the non-canal things, so the discs and the vertebral bodies. For and there on T1 the cord is fairly homogeneous. We're not looking at the T1 signal of the cord pre or post contrast for lesions. For for T2 images, when we get a good non-motion exam and you can see the gray and the white matter fairly well, we feel quite confident in the cord signal abnormality that we get. The issue is just with patient movement and breathing. We often will get noise sort of throughout the image, and then it's hard to know, is what we're seeing in the cord noise or not, and you sort of have to make a subjective decision. We've sort of found that on the T2 3D imaging that we have tried so far, we sort of lose the distinction between gray and white matter. Everything sort of becomes homogeneous, and I don't think we have tested enough, but we sort of felt uncomfortable saying that this is a normal cord signal. And so I think it just will require more testing, but it hasn't been a priority for the division. Yeah.
Yeah, I wonder if there'll be, ways that we could optimize the 3D imaging to improve the homogeneity of the cord signal. Could be an interesting thing, and some of the artifacts with like the CSF flow artifacts as well within the imaging, and I don't know, maybe there's ways to adjust the parameter space to improve the imaging. Next, Suzanne, give you the mic, and I guess tell us a little bit about how you use imaging in your practice. What works, what's frustrating, how could we help you?
So I think returning to the theme of degenerative cervical myelopathy and cord compression, I think there's a lot of variability among patients. You cannot predict what the exam is going to be like or how poorly off a patient is going to be based on their imaging alone. And sometimes patients will be referred to neurosurgery clinic with very dramatic imaging, severe cord compression. They maybe have a tiny bit of intrinsic hand weakness or maybe only a trace of gait imbalance. And, many of us, so the crude tools that we have, we look for T2 signal change in the cord. We think of it as sort of a imaging hallmark of early spinal cord injury. And then there were some publications a few years ago that suggested that stir signal change in the cord is actually a more faithful and sensitive measure of clinical dysfunction. But it would be great if there were a highly reliable imaging finding that tracked well with clinical severity. And I think this is part of what we're looking at in our trial. It would be great if you could predict who would do well with surgery, right? Because this is a condition of aging. And then oftentimes there's a competition between severity of cord compression and overall frailty, medical problems, ability to withstand surgery. And if there was some way on imaging to parse who is likely to have a functional recovery versus who isn't, then it would help us in choosing patients. And I mean, I know I'm asking for magic, but I feel like you're actually asking me to ask for that, right? Like shoot the moon. Yeah. So if we could.
We're going to figure it out tonight. Awesome. Really good. We can open this up now to some questions from the audience. Anything that you'd like to ask the panel? Got it.
Thanks. I have a question. It's also a selfish clinical research question, but also just to anybody on the panel. What do you see the role of quantitative MRI with acute traumatic spinal cord injury? A lot of some of the models that have been run for if my understanding at least, is that it's kind of within the 3 or 4 week window of timing after post-injury, and the segmentation is much clearer. There's the edema is better. It's clearer to see it. So do you think there's a role for trying to be really quantitative in a really acute image right after traumatic spinal cord injury? Or do you think the clarity of that image is always going to be too messy? The thick slices from a clinical perspective will always be challenging. I just kind of hear your thoughts on that side of it.
So maybe I could start. So the deep learning model that we developed, SCI-SEG, was done on acute, like subacute. So and before the implant, and in fact there is a value like from an image analysis perspective. There is also benefits in doing the analysis pre-surgery, because we don't have all the hardware that also deteriorates the image quality in most cases. So, and in addition to that, yes, we do see the edema pretty well, and like other cysts, for example, like kyst, many weeks or months later. But what we would be also after, and that the SCI-SEG model that we developed, is that in some patients we do see hemorrhage, for example, and there are a couple of studies suggesting that hemorrhage, the presence of hemorrhage would be a critical indicator for for prognosis. It's very difficult. I mean, we have a neurologist, radiologist here, so you could tell us more about that. But the radiologists that I've worked with found it extremely difficult to reliably identify and segment hemorrhage on our images. Maybe there is a miracle contrast, but yeah, that would be my 2 cents.
All right. Any other questions from the audience? Yeah.
I'm relatively new to spinal cord injury, but I was just wondering, in a clinical sense, what would be the role of MRI kind of at the moment in maybe after someone's had a spinal cord injury? What kind of images are required, if any, and when? Just for the context.
So patients are most oftentimes imaged acutely, and the imaging helps with surgical decision making. There are a number of controversies around, say, timing of surgery, and some related controversies around what constitutes a complete spinal cord injury, because patients who are in so-called spinal shock, which is also a clinical misnomer, may appear to be complete, and they're in fact not complete. So all of this goes into but the imaging is really to decide what operation to do, and that's there's almost no point necessarily prognosticating preoperatively, because the important decision that's being made is just, what levels do you go only from in front or only from behind or front back? But I had another related ask. So there is emerging data, and I'm not even sure this is published yet, that from the traumatic spinal cord injury field, from the surgery part, that Brian Kwan presented here at Stanford a few weeks ago, and this is data coming in part out of the University of British Columbia, that in fact spinal cord swelling, of course, we know can continue and probably peaks at about 3 to 5 days post-injury, kind of like brain swelling, and that a much longer, wider decompression than we would conventionally carry out as part of a decompression infusion procedure, say in the cervical spine, actually offers patients a better chance of more levels of recovery in their outcome. And this is kind of really changing our thinking. And this is sort of data hot off the press, but it relates to, bear with me, it's like a little bit of physics, but so Brian has separately been studying therapeutic spinal fluid drainage. So he'll put lumbar drains in spinal cord injured patients. And the idea, ultimately, it's a little bit like when we put ICP monitors in patients with traumatic brain injury or therapeutically drain spinal fluid from the ventricle, right? The idea is that you don't want a swollen cord to be under pressure. You want to maximize perfusion pressure in the cord, while minimizing the effect of compression and CSF space pressure on the ability to perfuse the cord, right? To maximize surviving tissue and surviving circuits. And so, but the issue is, if you put in a lumbar drain and start draining spinal fluid, and essentially that fluid column is occluded by edema, right? You're not actually achieving anything, and you could potentially achieve harm. So my ask is a CSF flow study. Can you do Fiesta type stuff, like when you study CSF flow through the ventricles? Can you study CSF flow around the cord in the presence of hardware? That's my ask, because that would be potentially really helpful at this stage where there's still a lot of unknowns in managing therapeutic drainage of spinal fluid and decision making around intraspinal pressure. So that would be a valuable thing to know acutely. But otherwise, the imaging, we use it just to decide what operation to do usually.
Thank you.
Yeah, can I ask that to Hugo? Hugo, what can we do with CSF flow, and what are you doing anything clinically here?
I would say the only like phase contrast imaging that we're doing is sort of for evaluating hydrocephalus, but we not for CSF, but on the cardiovascular side, they're doing 3D velocity encoding to sort of map the flow through the chambers of the heart, particularly for children with congenital abnormalities. And so, yes, 3D phase contrast imaging exists. I don't know that it's been applied to CSF or to the spinal cord. And then just coming back to the spinal cord injury question, I think it's often very clear to the neuroradiologist once we open the exam is like, okay, do they actually have a diagnostic question for us, or is this just for their planning? And if they come in with a severe spinal cord injury, it's very obvious on the imaging, and there's not much that we're adding other than providing a nice report. And so it's more what our role is in the acute setting is if there's an injury and it's not like we're going to surgery immediately, is sort of how close are you going to monitor this patient? Is it an unstable injury? And sort of things like that. Yeah.
Awesome. Any additional questions from the group?
Thank you so much. I'm also new to spinal cord imaging. I guess, what does a typical scan look like? What sequences do you do? How long is the scan time? Are they all 2D FSCs in different contrasts and different planes? Or, just curiosity. And any quantitative imaging that you do at this point?
Clinically, no quantitative imaging. So we do have some specialty sequences to look for, like CSF leak, where we'll do some Fiesta imaging, and then preoperative or pre-planning for CyberKnife. But I would say our standard imaging is we get 3 2D sagittal sequences, just T2 stir and T1. And then in the spinal cord, we will get 2D axial, T2 and merge, which is the medic. It's sort of a I forget the stimulated echoes, and it can provide. It often provides better contrast, but it is a little more susceptible to artifact. In the thoracic spine, we only get the axial T2, and in the lumbar spine, we get the axial T2 and an axial T1, primarily to look for a fat signal in the phylum terminale.
Follow-up question, Hugo. So you mentioned getting the multi-echo gradient echo sequence, so merge on GE, medic on Siemens. And Julian, it's part of the consensus protocol, generic acquisition protocol. In my experience, like 50% of them, like we use it quantitatively to identify the gray matter, but like 50% of the data sets, there's definitely, half the slices show pretty poor gray matter, white matter contrast.
The lower half.
Yeah, and then I've been looking at a lot of the clinical data from Stanford, and I'm curious, like what's it look like? And it all kind of looks similar. It's not as clean as what you'd think, right? Or the example images that you get. And I'm just curious, is that your observation as well?
Yeah, I would say most of the time I'm dissatisfied by both the axial T2 and the GRE, but often one slice or the other from either is better, and it's not consistent through the whole stack.
Okay.
But usually the merge, the medic, is quite poor as we get into the thoracic spine, upper cervical or lower cervical.
And how long is the full protocol?
So it fits into a 30-minute scheduled appointment. Typically 10 minutes of that is for patient handling, so 20 minutes on the scanner, and about 15 minutes is gradient on time.
I have another question to Dr. Decker. So I'm wondering about the hardware in many of these patients. Is there any special metal artifact correction sequence used? For example, are you applying like any view angle tilting in clinics?
We are not, and the images don't look good. Yeah.
So I pretty much have no knowledge of spinal cord imaging, but out of curiosity, Sandrine, in your presentation, you showed different metrics like AP diameter, transverse, solidity, or something else. Do these each clinically, and this can be a question to all, represent something different, or are they all just measures and we're trying to find which one is the best biomarker?
I think, for example, like cross-sectional area is usually used for like atrophy, so it would not, so it's more like generalized atrophy compared to a compression where it's kind of already visible. Then I think why like AP, anterior posterior diameter, I think it's used a lot just because a lot of clinical scans have sagittal image. So if you have 2D acquisition, then computing, I would really not recommend computing cross-sectional area with that. So that's when, for example, your AP diameter would be relevant. But then it's always the thing of positioning, because if you're not really at the center line of the cord, then you may not capture the right metric. And I didn't show some image, but mainly like compressions can present themselves in, I mean, they can have different shapes, and it's quite hard actually to capture all these shapes. So I think that's why we really try to have like just the more metrics we can have to help. For example, if you have like triangular compression, sometimes the CSA would maybe not really be different. Your anterior posterior diameter would probably also not be different. Right, left either. And I think that's why we're trying to work on getting these like symmetry metrics, because if you have a triangle and you flip it, then you would get like this asymmetry in this plane. But for example, like triangular type compressions is hard. I think one thing, like trying to correlate these metrics with clinical symptoms, it has been like a challenge in the past year, and we really tried to kind of correct for inter-subject variability, correct for like the shape of the cord, and one also thing of the limitation is really trying to capture all of these changes that are still hard to capture.
I have a question for you, Sandrine. So you're looking at cross-sectional area and AP and transverse area. As patients age, they lose a lot of height, and a lot of that is in disc and vertebral bodies. The cord seems to still always terminate at roughly the same spot. Is there any craniocaudal volume loss over time? Have you attempted to measure that?
I think it's pretty rare that we like quantify like volume-wise. Usually we look more at the cross-sections. I think there is some atrophy of the cord with age. We have not looked if there's like shortening of the cord, but I think that would still be something interesting to look at. But the challenge is always like we would really need some longitudinal data of the same person, because there's just too much variability. But in the cross section, like there is some atrophy, and but it's always also hard to capture what are the normal changes versus kind of pathological changes. So we're trying to kind of put together these normative database, but it's always when we arrive at a certain age, we see a lot of kind of mild stenosis, and then we kind of never know what, like, oh, do we still include them? But then if we compare to it, it's still maybe abnormal, and we're quite always unsure on what to do with these. Yeah. If they look abnormal, but the person doesn't have any symptoms, do we still consider that healthy controls or not? And yeah.
And then so we are going to be starting data collection on a new study with 120 people across the lifespan. And we're going to do full spine imaging of the 0.8 millimeter isotropic resolution. We didn't plan on including brain imaging, but maybe we should, just so we could have the whole CNS covered with vertebral levels, and you could kind of look at the volume relative to vertebral levels and stuff like that. Still would be cross-sectional, so it doesn't help with the longitudinal component, but that would be a cool project to do.
I have a question for Julian, and others can chip in also. When we looked into the spine acquisition protocols, what's the main sequence that, if you use that for looking into the vasculature in the spine, like is it the SWI, or do we use any other sequence for looking into the spine vasculature? And I have another question, have we had any experience of, or what's the feedback of Spinico EPI for functional MRI images in your experience? Yeah.
So for vasculature, well, for the venous part, there would be SWI sequences. It looks okay, in like, obviously if you have hardware and so on, it's very difficult because they are like phase sensitive images. SWI will give you a nice mapping of the veins, and well, you could use like time of flight for the rest of the vascular system, arteries. I haven't tried time-of-flight imaging in the spinal cord. I don't know if you have some experience.
I don't. I hear that it's not great, so we will do contrast.
Yeah.
Like time-resolved imaging.
Yeah. And so the other question was about the
Spinal.
Right, Spinal. That's why I forgot about the question. Well, there is a large body of publication from Patrick Stroman's group that is controversial, and I think I tried it when I was doing my PhD thesis 20 years ago, and I didn't have good success. There have been follow-up publications in the 2008, 2010 from Joachimsen. Was the first author. There was Bouwman as well, Bouwwan, something like that, who also published on Spinal API for fMRI. And so not so many publications outside of Stroman's group, which is why it's controversial. On the other hand, this has been used in the brain because one of the advantage of Spinal is that you are less sensitive to the draining effect in the venous compartment, so you get more spatial specificity. But you also lose a lot in sensitivity, and sensitivity is also a big problem in spinal cord, right? So I guess it's still an open investigation. Yeah.
There is not too much literature about Spinal API in the functional.
Not so much.
All right, we have 5 minutes. We have to be out of the room, or 5 minutes and we're 10 minutes. Oh, I saw a hand of 5. 5 minutes? You have a question? Yeah. Oh, it wasn't in 5 minutes. Sorry.
And we have 10 minutes. Yeah, thank you so much for the amazing discussion. My question is mostly for clinicians, but I would like to get all the opinions of our panelists. So what do you think about these deep learning based reconstruction approaches? Do you think are they widely used in the clinical practice because they enhance image quality? Are you afraid of hallucinations, or did you have any personal experience? Yeah, what is your personal experience with that?
Oh, here.
Oh, yeah, thank you. Yeah, I think so. We're primarily GE shop, and DL Recon is turned on I think all of our 2D sequences. I think you can have mild, moderate, and severe. Those aren't the words, and we're sort of in the medium level for what setting we have. And I think the images looked a little more cartoonish to us because it got rid of a lot of the noise. For in terms of hallucinations, we use it intracranially as well as in the spine, and we're pretty not worried about it at this point. And yeah, I think sort of the question becomes, now that we're comfortable with it, can we sort of accelerate some of our imaging parameters, and then which will lead to more noise, and then get rid of the noise with the DL Recon. I think we've had some minor gains with that, but sort of it's an open question about how much we're comfortable pushing it. You don't mind the images?
I don't have anything to add.
Yeah.
So I think just to add, because you were talking about the on upcoming 120 subjects that you want to cover for the whole brain and spine. I mean, this is where maybe a little bit of aggressivity on the parallel acquisition and maybe the sparse sampling could make sense. If you don't want your participants for an hour in the...
Yeah, no, I think that's our plan, is to do mild, both compressed sensing and deep learning reconstruction. Essentially because, this would be on the Siemens, which they're 3D, or at least right now we don't have deep learning reconstruction on 3D sequences on the SEMA X, but we don't know if that's a licensing issue or something. We're not sure. We're looking into that.
Actually, on that note, I would recommend keeping the raw data, and then you might have like an interesting study comparing the effect of deep learning on maybe like volumetric measures.
Yeah, that's great. All right, I've got one last question to end this panel discussion. Sandrine and Julian and your team, you guys are, we're almost there. I think it's a data problem almost, that we could quantify everything we could see, right? As long as we can find someone to accurately segment it and that we can accurately view whatever we're trying to quantify. So how much data do you want as a neuroradiologist? How much do you want, Suzanne? And there's going to be a threshold that we're going to have to prove to you that there's going to be clinical utility of these measures, right? And it's not a yes or no or any sort of question. Just kind of we'll end it with that. What would you need, you think, to be able to use it better clinically, and kind of how can the data help?
Yeah. I think one thing that I wasn't here for the whole day, so that I'm not sure how much was touched on, but there are many things in the spine that can cause symptoms, pain. There's vertebral body edema, there's facet edema, there's perifacet edema, there's soft tissue changes, and then everything compressive in the canal. We do level by level sort of description of this, and we sort of make a quick judgment, like what's the most severe thing in the case. I'll spend more time on that and less on the other. But I think something that I would want is something that can segment and sort of explain the end plate edema at every level, the facet change and edema of the facets, and pre-grade all of the canal for me, and then I mostly review it. I think some of that is like, is it AI or is it just algorithmic? And I would like to be more consistent in what I'm calling moderate versus mild. So that's sort of one, and then knowing that distinction sort of matters.
So I would love to be able to follow the tracts, but I'm very interested in spinal cord tractography. So if that's something you could measure more and in more detail and in smaller things like in humans, but also maybe in mice. And I'm interested in being able to follow specific tracts, So I think as a clinician, I sort of feel bound by, when a patient comes in with an acute spinal cord injury, I can stabilize and decompress the spine. And, now I'm going to do a wider decompression and a longer stabilization and maybe put in a lumbar drain. But ultimately, I can't necessarily do that much to change the outcome within the spinal cord. But that's where the work in my lab comes in. And I think for those of us who are seeking experimental treatments that are going to make a difference to outcome, being able to look at the spinal cord both in preclinical models and in patients, and start looking at the tracts, I think would be an important biomarker or readout. So yeah, spinal cord tractography, that's what I think that it's like you can't get too much detail in that if you just want to nerd out.
Yes, I'm glad this is on the table, because I thought about it when you asked the question to Sandrine, can we actually see some of the tracks with the MRI? And so we could see some of them, like for example, the same UBC group, Corey Lawley, Shannon Collin were showing some very nice myelin water fraction imaging where you really see a contrast of the fasciculus gracilis and cuneatus. So these ones we can see them with our naked eyes. The other tract, not really. I mean, we know there is some very very signature of axon density, axon size, myelin density, and so on. Fancy like diffusion microstructure methods could separate them, but I would say we're not there yet in the spinal cord. Now about tractography, the problem with tractography is that it's very easy to get those fibers that just represent the the bulk diffusion direction and in a particular voxel. And when there is some consistency across neighboring voxels, you would just get a tract. But that doesn't mean that for one, the tract corresponds to the fasciculus gracilis or corticospinal tract or so on. In order to answer that, you would basically need to go to the projection, and then the problem is that you go through the pyramidal tract, and then there's some crossing, and then there's some noise, and maybe the field of view stops here. So there is this very big problem here, and problem number two is the resolution. Usually with diffusion weighted imaging, we don't have the luxury of being able to distinguish every tract. So I lost faith in tractography for like many years ago. And I'm more into the atlas-based analysis, where yes, maybe we do make an error in this particular patient, that maybe the corticospinal tract is smaller, and we use a probabilistic mapping based on hand drawings from Gray's Anatomy Atlas or something. But would tractography give you more accurate results? I don't think so. It's a very controversial statement.
To end.
Yeah, maybe if you're just in the cervical spine, then you might be able to follow down to some extent. I know that Dr. Steinberg does tractography for cavernous malformations in the brainstem before he does it, and cervical spine's pretty close. But yeah, above the decussation.
Corticobulbar tractography. What about that? Corticobulbar.
Well, then the question is, you're talking about malformation or like the presence of tumor, where one of the interests is how does the tract deviate. The problem is that we are not measuring the tracts; we are measuring diffusion of water.
Right.
And if there is scarring tissue, you would get also an anisotropy, and you would get a tract. The problem is that we are not specific. We feel that we are specific to the tract because we see the tracts, but it's not necessarily white matter. It's just anisotropy.
What about in an experimental animal if you inject something into motor cortex?
Oh, yeah, that would be great. But,
Yeah.
but then it's not translating the MRI measures because ultimately we want to then validate that to say, oh, then we can use it in vivo in humans, but the translation part still needs validation.
Yeah.
All right, that'll close up the panel discussion, and then next we are heading over to the Lucas Center for the hands-on structural imaging. At 3:30, you need to meet Sandrine in front of the Lucas Center, which they could follow Sandrine over to the Lucas Center. That might be better, then nobody gets lost, but...
Yeah, sometimes, so they can also take something.
Okay, we have a little time.
Murphy,
3:30 in front of the Lucas Center.
I leave from here at 3:20 to the
We're going to leave at 3:20 outside of the building in the front. You can join us. We won't be holding signs, so remember our faces. But thank you.